This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa New Zealand and is committed to meeting its obligations as te tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynecology through conversations with leading experts. Today's episode is a little bit different. We're discussing recommendations for breastfeeding care and counselling, and this is probably an area where we're lacking a lot of research and lacking guidelines. But I've got two experts here today who are going to help us in terms of talking about managing potential complications, impacts of medications in breastfeeding, and if we need lactation suppression. I'm Dr Heather Waterfall. I'm a generalist obstetrician and gynaecologist from South Australia. Joining me today are international board certified lactation consultants and RANZCOG GP obstetricians, Dr Briony Andrew and Dr Jacqui Wagner. Could you both please share a bit about yourselves?
I'm Jacqui Wagner and I'm a GP obstetrician providing intrapartum care in regional South Australia. I also work in private general practice providing holistic care to women and their families and their babies, from antenatal to postnatal care, including lactation work and care of babies.
Thanks, Jacqui. Welcome.
So I'm Dr Briony Andrew. I'm a GP obstetrician and lactation consultant, and I also provide intrapartum care in rural South Australia. I'm a co-founder of Adelaide Mums and Babies Clinic, and we specialise in, I guess, the closest thing to breastfeeding medicine that you can get. We offer hour-long mums and babies consults where we fix breastfeeding problems, slow weight gain, infant sleep and unsettled babies. We also do parents groups and antenatal education on breastfeeding and bring baby home, and we have an online education as well. We were awarded the South Australian Telstra Best of Business Awards a few years ago for accelerating women because our format is fairly unique across Australia.
Before we begin, we disclose some conflicts of interest. My personal conflict of interest is that I'm an owner of a private practice, and from a personal note, I also benefited from the care of a GP lactation consultant when I went home triple feeding my twins. Jacqui, do you have any disclosures to make?
I have no disclosures.
Briony?
I am also an owner of a private practice, and that's about it.
Thank you. Let's get down to discussing it. Briony, let's start. Why is breastfeeding medicine important, and why are we talking about it today?
If you think about it, breastfeeding is a universally human experience. It's pretty sad that it is the only organ of the human body that doesn't have its own breastfeeding medicine specialist. There is very little research into this area, very little education, and so it's been an area of healthcare that has been well and truly left behind. I think intellectually we all know the benefits of breastfeeding, short-term and long-term for mother and baby, and how impactful this can be over the lifetime, yet there hasn't really been any structure behind that to either do further research or even allow people working with mothers and babies to give evidence-based advice.
I suppose from a RANZCOG perspective, it's in our curriculum, but I'm not sure that we're really taught that much in terms of the actual breastfeeding medicine. I think that's part of what this episode today is about. So firstly, looking at what can the obstetrician do to support pregnant people with breastfeeding. Firstly, antenatally, what are the key considerations before birth?
I think that's a really key area to raise during pregnancies, and I think we're very privileged as GP obstetricians to really care for families across the lifespan, and we understand the power of raising those conversations early. So the key things we would look for would be identifying women who are at risk of breastfeeding problems early during their pregnancy. So these might be women with metabolic conditions, those with gestational diabetes, those who've had previous difficult lactational journeys, so previously having difficulty breastfeeding, and particularly those who've had breast surgery previously. These would be the women we'd want to identify and start planning ahead for what feeding may look like for them. It's really important that the idea of antenatal expression of colostrum is raised early. So I think most of us are aware that this is really powerful for women with gestational diabetes, and then they can use that colostrum postpartum when the baby has their sugars checked, and we can give colostrum instead of formula in that situation, which has all the benefits of colostrum. The other benefit of antenatal expression is it's a skill to be learnt, and women often have a bit more time before baby arrives, particularly before their first baby, than after they arrive. And there's many situations outside of gestational diabetes where women may benefit from being able to skillfully express their colostrum. So this might be unplanned separation from mum and baby, engorgement, nipple trauma, difficulty attaching. So a great skill to have beforehand. I think having these conversations antenatally also helps women to plan ahead for who are going to be their care provider teams after having a baby. And obviously Brian and I carry our biases here, but we love seeing women who are able to plan ahead for that 2 and 6 week check with somebody skilled with mums and babies. And often people who are skilled in this field are very difficult to book at short notice. So this can be planned for ahead. Going back to the antenatal expression of colostrum, I think it's really important to know that we have so much evidence that this is safe. It can be done from 36 weeks. We recommend 10 minutes twice a day to develop the skill, with the important caveat that up to 50% of women won't actually get much colostrum at all. And this is totally normal and doesn't indicate that they're going to have future supply issues. It's just about building that skill as much as building a stash. And women over a course of 4 weeks of expressing might only have a total of 10 to 20 mils, and this is completely normal. The other benefit of starting these conversations early is that we sometimes shift the focus from birth planning to parenting our baby and thinking about how that's going to look for each individual family, thinking about managing an unsettled baby, managing feeding, and what our village looks like. Because we all know there's so much focus on the birthday, but there's so much that happens after that.
Briony, did you have anything to add to that?
Just with antenatal expressing, I think for the women that aren't getting very much at all, that can be a little bit soul destroying, especially when they wanted that insurance policy for their baby. So I tend to suggest they flick their goal to breast stimulation. So we know that their milk will come in earlier if they have primed their breasts during their pregnancy. And so those mums, even without an insurance policy supply, will be more likely to leave hospital exclusively breastfeeding.
And even having those conversations around what breastfeeding actually looks like. I think many people are quite shocked by how much time it takes to breastfeed babies, to establish supply, and shifting that expectation that they're going to be doing everything they were able to do antenatally, plus breastfeed their baby and roll on with life. So I think that can be a big shock for lots of people having their first baby, as we know, but actually having those conversations beforehand is really powerful.
And I think, especially for first-time mums, I noticed that they, will comment, well, breastfeeding's natural, surely it should be easy. And they seem really shocked when they find out just how hard breastfeeding often can be. And I think that they then feel really isolated and think that I must be the only one. I think that leads to a lot of breastfeeding grief and potentially a lot of self-doubt as a mother. And I also find that women that may enter, I guess, the end of their pregnancy being somewhat ambivalent around what they're going to do with feeding their baby are completely not expecting this kind of like guttural instinct desire to feed your baby at the breast. And then when it becomes hard, they don't really know who to turn to. So I think the normalising of breastfeeding is super important, as well as planning just at least so that they know who they can access for high quality support if they have trouble.
I think all pregnancy care providers can develop a directory of who they can refer their women to, and thinking about early appointments booked ahead of people who are skilled in this field. And I think there's a emerging field, certainly at least in every capital city of Australia, of medical professionals who are also international board certified lactational consultants who can bring evidence-based medicine into this field as much as we all can. And I think giving women ways to access evidence-based care is really important. Otherwise, they are literally left to ask Facebook or ask their friends. And I think it's astounding how little breastfeeding education there is across many professions, medical professions. And I think giving women evidence-based places to start is really powerful as well.
I think most women are also shocked at the amount of conflicting advice from the minute that they have this baby, not just about breastfeeding, but of course all parenting things. And again, they're left even more confused and bewildered. They are most likely, I think, to turn to their trusted healthcare professionals, which would be their obstetrician, if they've had a relationship with a private obstetrician, definitely their GP, possibly their midwives, and are probably really surprised that these people actually can't give them a whole lot of support, or they're going to give them conflicting advice. I think a lot of healthcare professionals will inadvertently bring with them advice that maybe they learn either on the job that was also not evidence-based or from their own personal breastfeeding experience. And when we look at the curriculum in, say, medical school, general practice, paediatrics, obstetrics, midwifery, there is very, very little on breastfeeding.
I think that really leads us on to that post-birth care. Briony, what do you think obstetricians need to know to support early postnatal breastfeeding?
I'm really passionate about the combination of uninterrupted sort of first 1 to 3 hours, what has been referred to as the golden hour with skin to skin. I think en masse we are doing a much better job now than we did, say, when I had my first 12 years ago, with not separating babies, especially, post-caesarean section, baby would go to the nursery, mum's left in recovery. I'd like to think that is no longer universal practice. So I think, obstetricians encouraging reduced separation of mums and babies as much as they can in that first 3 hours goes a long way. And then the next thing would be for the obstetricians to understand just how frequently these babies need to feed in the first couple of days in order to help mum establish and potentially maximise their future milk production. So mums don't get this time back. This is sort of when we're still producing colostrum, our milk hasn't come in yet, and we are putting down prolactin receptors, is the theory at least, onto our breast tissue in response to stimulation of the breast by either the baby suckling or potentially some hand expressing or pumping. And although the baby may be okay to not have a breastfeed for potentially up to 10 hours before they need a blood sugar, I think that we have forgotten that there is another very important person in this equation, and that is the mother, and her breasts need to be stimulated regularly.
So I suppose then as an obstetrician, if we know that the baby is going to be taken to the nursery post a caesarean section, then we could empower the woman to ensure she's got some syringes so she can collect colostrum, that we can make sure that someone is there supporting that, so exactly. That if they are separated, then the breasts are being stimulated.
That's
and
right.
Her body's knowing right now is the time to transition to making some milk. This baby is hungry and needs to be fed, even if the baby isn't necessarily with her.
That is literally as simple as a sentence to the midwife taking care of her of, why don't you show her to do some hand expressing and we'll collect some colostrum to store for the baby. This is not difficult, time-consuming conversations.
It's just keeping that part of the aspect of care at the forefront. Every 3 hours comes around really quickly in that postpartum time. So having that at the forefront of our tick mother, baby, breasts.
I like that, tick mum, baby, breasts. And even if mum is unwell and she's the reason why she and her baby are separated, that we as obstetricians can also check in and see, was breastfeeding part of her plan, and can we help support that even if she's unwell, I think is something we can do as obstetricians.
We can still honour that goal, even if it looks like something a little bit different for a day or two. We can still honour that and keep it at the forefront, because that will mean a lot to her. As Briony said, that important few days, in a few days' time, that is going to be gold to her.
So talking about some common breastfeeding complications, what are the current recommendations for mastitis and blocked ducts? Because these are the women who walk into our women's assessment units and they see us as obstetricians in that first 6 weeks postpartum. And I think a lot of us aren't really well versed on what the current recommendations are.
Yeah, that's a really important, really common presentation. And I think it's really understanding that spectrum of inflammation from the full breast, the full, hard and painful breast, and then the milk stasis being what predisposes us to infection. So looking for the early signs of mastitis, so a red, painful area, thinking about fevers. And the first thing would be to be moving towards adequate drainage of this breast. There's overfilled areas of the breast that are inadequately drained, and we're getting that stasis of milk providing inflammation. So actions that work towards anti-inflammatory actions are very important, like Nurofen, cool packs, adequate drainage of the breasts, heat before a feed, cool after a feed, and often without overt signs of mastitis. We can sit in this space providing those ways of managing the woman for the first 12 to 24 hours. But then if we've got overt signs of mastitis, then we move towards treating with antibiotics, which would be a 10-day course of flucloxacillin in the absence of any allergies, because most cases we know are probably staph from the skin. But we don't need to pump and dump that milk. That milk in the setting of mastitis is very safe for baby, and that's really important. And allowing her to not have an episode of inadequate milk drainage that then she comes out of with a very low supply, because that's a story that we'll see very often, a difficult case of mastitis, then tanking our supply a week or so later. It's also making sure we really optimise the concept of fit and hold, so making sure that the baby is latched well, but latch is not just about the baby's mouth and the nipple, but the whole fit and hold of the baby and the mum together is such that not causing ongoing microtrauma. That is a really important concept. The baby's not on and off again. They're both fit, comfortable and feeding together well, because ongoing microtrauma will predispose to recurrent episodes of mastitis. So we need to look at why did this happen in the first place as well, rather than just providing fluclox and rolling on. It's addressing fit and hold milk, looking at supply issues and making sure we're draining those breasts really well. There is not a huge amount of evidence for therapeutic ultrasound for mastitis, but it falls into one of those areas that is very poorly studied, and so there's not a lot of evidence at all in that space. And anecdotally, there are women who benefit from this, and that can be explored as well. But again, yes, lots of absence of research in this whole area.
I think mastitis is fascinating because I can't think of any other human infection, unless, say, the flu, where women can feel like death but not have a bacterial infection yet. So people can walk into a cinema feeling completely fine. By the end of the movie, they've got a fever of 40 and rigors and this warm breast, but it doesn't actually mean they necessarily need antibiotics yet. And so I think just feeling safe, if you're the provider of care, to encourage frequent effective milk drainage and that first aid for mastitis, which is ice, anti-inflammatories and frequent milk removal. And women can often reverse this in 12 to 24 hours.
Moving on then from women who've got oversupply to what about those who have undersupply and the issues associated with low supply? And can you give us some guidance on prescribing domperidone?
Most physicians are a little bit hesitant to prescribe domperidone because certainly in America it has a black box warning, and we are, using it off-label in Australia. The black box warning is simply because it was given in high doses intravenously to palliative care patients and they got ventricular arrhythmias. Clearly this is not our patient load of breastfeeding mothers. But when they looked at big studies of women that had very high doses in US and Canada, the only people that had a ventricular arrhythmia were those that had had it previously. Having said that, as much as I am very happy to prescribe domperidone to most of my patients, it's the prolonged QTC that is the risk with domperidone, in particular if it's prescribed alongside another medication that does the same. And so these might be SSRIs, ondansetron, or maybe fluconazole, and some antibiotics in the context of, say, breast thrush or mastitis. If that's the case and they're on two agents, I usually suggest an ECG about 1 week into the course to just make sure that there is no QTC prolongation. I am yet to find a mum that has one. The studies around domperidone all exist in an artificial setting of NICU mums pumping to increase their supply for their preemie babies. So we actually don't have any studies on domperidone in direct breastfeeding pairs, but the work we do have shows that 1 tablet 3 times a day will increase milk supply over a 2-week period, and then if you continue on that dose, there's a maintained production. Similarly, if you double that dose, there is a proportionally increased amount of milk production. However, every individual mother will have a different, supply. So I also like talking about lots of fluid alongside that, and most importantly, we need a well-feeding well extracting breastfeeding baby and that frequency of breast stimulation as well.
And then following on with the women who are advised to triple feeding being feeding, pumping, bottling that baby, do you see domperidone as part of that as well?
Yeah, so triple feeding is pretty commonly suggested when either we've had excessive weight loss in baby and often because we feel like mum's supply is down. I think this can be prevented if we are better at recommending those frequent feeds in the first few days to actually get mum's supply to be maximal. If we're in this triple feeding regime, we need to understand how onerous it is. And so, what we are asking is for women to breastfeed and then to give baby a top up in a bottle and then for mum to pump. And if we don't put limits on it, it's very easy for that breastfeed to blow out to well over an hour. Mostly because the babies that we're dealing with are probably not very good feeders. They're often our sleepy feeders. They're not transferring milk very well, which is part of the reason why we're in this problem. And so I think, telling mums to cap how much time they spend at the breast, and I normally talk about switch feeding. So we would suggest offering 4 breasts in the same amount of time as you would have offered 2. So we're actually going to get more milk transfer in the same amount of time as the breast will refill in between sides. And I'd probably cap that at about 30, no more than 40 minutes. Baby then gets a top up according to a paced bottle feeding style, and then mum would double pump for about 10-15 minutes. But we want to get all of that done in 1 hour so that they then have 2 hours off before starting again, because we usually suggest this baby is fed 3 hourly. I 100% do not recommend triple feeding at night. So nights for sleeping, I suggest usually in this scenario, mum would pump and the other non-breastfeeding partner would bottle at the same time so that everyone can get back to sleep as quickly as possible.
Have you ever wondered how a RANZCOG clinical guideline is developed, or are you unsure of how to adapt the guideline into clinical practice at your workplace? Join RANZCOG's Translating Research into Practice workshop on Saturday, the 23rd of May, and experience a deep dive into the college's evidence-based guideline development process. You'll learn the practical skills of assessing evidence, translating it into practice, and integrating clinical guidelines within your own health service, and much, much more. You can attend in person at the college in Naarm, Melbourne, or online via Zoom. Register now at ranzcog.com/events and receive CPD hours for your participation.
So moving on then, for that woman who then wants lactation suppression, both either immediately after the baby because she's never planned on breastfeeding or remotely after birth, talk us through what's available, what's recommended, what can we do for lactation suppression?
I think that we divide this into the woman who has never lactated before. So these are those loss of baby early or in those very difficult situations. We would look at early provision of Dostonex within the first 24 hours. Ideally, we would look to not stimulate the breasts, have a tight fitting bra, and then seeing over coming days if the milk does come in and then supporting them through that. But using the idea that we are going to hit it early with the Dostonex and provide that education early and then review as needed. This is a very difficult situation, different situation to the lady who has previously breastfed before and now is seeking to end. And sometimes these are very tricky situations when they're seeking to, for terrible traumatic reasons, having to abruptly cease. Then for maternal illness or baby's unwell, then we have to look at it through a different lens of gradual suppression of that lactation. We can't just stop breastfeeding, otherwise they will end up with terrible mastitis, and we can't just switch it off. So Dostonex can be provided. It is less effective when it's provided outside of the first 24 hours. We will still need to empty the breast to some degree to prevent that spectrum that we talked about earlier of the full hard breast to inflammation to eventually milk stasis and mastitis. So sometimes we may pump for a small amount of time to soften the breast, to get rid of any lumpy or hard bits. But if you pump to empty the breast, then your breast is saying, okay, cool, you want me to make more? I'll make more, because of the supply and demand aspect of breast milk production. The other medication that is really useful is Sudafed. And so it can be offered 60 milligrams 4 times a day and reviewed again soon after, and that will reduce breast milk supply significantly. But often for established lactation, it is a combination of emptying the breasts as much as you need but no more, as well as that medication use and education for that woman as well.
Yeah, so it's a running the breast full over time that will dial down milk production. So that's what you're trying to do in those women. And to make it quicker, I do find, good old pseudoephedrine, so not the one that you have to show your driver's license for, does make that process significantly quicker. So apparently just one tablet of 60 milligrams will reduce supply by 25% in 24 hours. So that is definitely a medication we avoid in breastfeeding unless we're really keen to turn down that milk production.
Talk to me about medications, anaesthetics, alcohol, recreational drugs and breastfeeding.
Big topic.
Yeah, do they mix? How do you counsel women who come to you with concerns? Because so commonly I hear, the anaesthetist has said I have to pump and dump because I'm having a colonoscopy and he doesn't want any of those medications to go through to my baby. What can we say?
I just think this is such a classic example of the systemic, lack of support that medicine provides women and then their babies. At the end of the day, there's so few medications that we can't give to a breastfeeding mother that it is borderline negligent for healthcare professionals to not quickly look up a database to check that the advice they're giving about this is correct. We wouldn't tolerate such poor advice in any other area of medicine, yet it is frequently poorly given in around breastfeeding and especially with medications. So this is, I think, fairly easy to think through for yourself. First of all, if you can give a medication to a pregnant woman, you can pretty much give it to a breastfeeding woman. So clearly, in pregnancy, they have the same circulation across the placenta, and in breastfeeding, there are more membranes and barriers. So if it's safe in pregnancy, it's safe in breastfeeding. The only exception there is codeine, which we are generally avoiding due to the different metabolism that may exist with liver enzymes. After that, you think, can I give this drug to a baby? If I can give it to a baby, I can give it to a breastfeeding mum. Is this drug going into the mum through a non-oral route? So if it is, it's probably because the liver will destroy the drug, which means that if any of it ends up in the breast milk, the baby's liver will destroy the drug and it will not be absorbed. And then you have to think about maybe size of the molecule. So if you know that it's a really big molecule, it's very unlikely to cross into the breast milk and go to baby. So that's just some very quick basics. Then you might want to think about things like, timing of dosing and things like that as well. And obviously we're looking for lowest effective dose for shortest amount of time when we're talking about medications and safety in general. There are plenty of free resources that are so easy to access. LactMed is probably the obvious one. It is quite, medical. So patients may have trouble understanding it, but it is very good for healthcare practitioners. Then there is Lactation, which started off in Spanish, but it is in English, and that is very easy traffic light system to understand. Jacqui, what do you use?
I quite like the mother to baby fact sheets because there's a lot of medication that is written for consumers, which actually covers both pregnancy and breastfeeding, and it's a lovely PDF you can print out and give that woman to go home as well. Each state would be slightly different, but in South Australia certainly we can contact a tertiary referral hospital and speak to the pharmacists who are very skilled at accessing all these databases and more, and providing a very individualised and really acknowledge the nuances of risk and benefit. I think gone should be the days you are pregnant or you're breastfeeding so you can't have it. I think it's having that conversation with the woman, and I'll actually put the lady on speaker, the pharmacist on speakerphone, and have a three-way conversation with my women, and we'll make a plan together with a certain medication. And in many situations, the benefits will outweigh the small risks. And again, it comes down to a paucity of data. I always say to my women, no pregnant or breastfeeding woman puts her hand up to be part of a trial to see if a medication is going to hurt her baby. So we don't have the robust data. But actually real life experience means that we can be very comfortable with many, many medications. And we are serving our women better if we're treating her better with the medications that she needs rather than just saying you can't have it because you're pregnant or breastfeeding. Yeah. And I think you can't read the product information because every product information says...
All over-the-counter medications say do not have if you're pregnant or breastfeeding.
Yes. So it's very easy to access that with a phone call or a review of a database and a discussion with a woman. It's not hard to access that information.
So when it comes to one of the other questions, Heather, about anaesthesia, this is really easy. If the mum's awake, she can breastfeed. It is as simple as that. And so I think the real issue about breastfeeding women having surgery is actually how to manage her breasts and, of course, feeding her baby around the time of the operation. That is way more important than any risk of the actual anaesthesia agents. So the things to be mindful of is you probably want the woman early on the list, so you don't want her fasting for too long. You don't want to get dehydrated. So if she is going to be fasting, she definitely needs some fluids. She's going to have to think about how we're going to get the milk off leading up to her surgery and then straight after her surgery. Can she bring baby in? Can she have access to a breast pump?
What about alcohol and other substances, which are a bit more discriminatory, but we also don't want to tell women for the entire duration of their breastfeeding journey, which could be a couple of years, that they can't have an alcoholic drink if that's what they want. We don't want people to cut short their breastfeeding journey because they feel like they're being socially isolated from their friends because they can't have an alcoholic drink at the same time. What's safe?
I do think that alcohol and breastfeeding can mix, and I'm not quite sure why our public health measure is so strict about this. I suspect it's because it is a public health measure, and so therefore I think we don't want people to confuse pregnancy and alcohol with breastfeeding and alcohol. So therefore it might be deemed safer to just suggest if you're planning a family, then sorry, you can't drink. Of course, we know that's unlikely to actually happen. So if the things we do know about alcohol and breastfeeding is if you hit 5 standard drinks in a sitting, then you will get a drop-off in your oxytocin release.
You shouldn't be parenting.
This is going to be my point, Heather, is that I think that if you're drinking to the point where the alcohol might maybe a little bit affect your breastfeeding, I think inadequate parenting is the biggest risk, not the alcohol in the breast milk. So 5 standard drinks, we're talking almost a whole bottle of wine to yourself in a sitting, and we might see a drop or a blunting of that oxytocin response, which means the baby might have to work longer for a letdown. So that we do know. I don't think it's necessarily a big deal despite the 5 standard drinks and then parenting. Other than that, if you just do the simple maths, we know that alcohol in the blood will travel very easily across into breast milk. So someone's blood alcohol concentration will be the same as their breast milk alcohol concentration. So that also means that it follows the gradient, the concentration gradient. So as you sober up or as your blood alcohol level drops, so too will your breast milk alcohol. So you don't have to pump and dump. Alcohol is not stored within the breast milk once it is there. The next thing to think about is, well, how much alcohol will then be in this breast milk? So if we take something like, a blood alcohol of 0.05%, so we shouldn't be driving. And I think for most people, if they're having some drinks with a meal, it's probably a little bit hard to get to 0.05. That's a reasonable amount of alcohol. So say your blood alcohol is 0.05, your breast milk alcohol is then 0.05%. So when we're talking about alcoholic beverages, it wouldn't even register as an alcoholic beverage on food safety standards. Pear juice, bread is like 0.01%, sometimes up to 0.1%. So we're really talking about a beverage that is once the baby then drinks it and then converts that into their own blood alcohol, it simply cannot be, the baby is not going to get a blood alcohol level from that low level of alcohol in mum's breast milk to become something more interesting, like a 0.5% alcoholic drink, which is still, when you think about wine being up to like sometimes 16%, still not very alcoholic. That mum is probably dead from alcohol poisoning at 0.5%. So again, I think the biggest risk here is inadequate parenting rather than any concern about the alcohol content in breast milk affecting baby's brain.
And I think the other point regarding recreational substances is to take back and look at the bigger picture when we are potentially counselling women to not breastfeed in this situation. And sometimes we look at our more socially disadvantaged women that if we look at cigarette exposure, marijuana use, alcohol use, if we come down on the hard line that woman should not breastfeed, we're reducing her and her baby's access to benefits in terms of long-term reduction of her metabolic risk. We look at the reduction of SIDS risk in those families as well. And I think we need to take the whole context of that family where it may not be perfect, but the benefit might outweigh the risks on a more global perspective of that family's well-being. And I think that's really important when we're judging whether somebody's safe to breastfeed or not.
Definitely a harm minimisation approach. So if we look at something like cigarette smoking, nicotine is the link with SIDS, and so it can actually reduce the baby's ability to rouse when they are sleeping, which then means, of course, nicotine replacement therapy to try and quit smoking is not advised either for the same reason. Nicotine travels very easily across the bloodstream into the breast milk, But there is a big benefit in breastfeeding and preventing SIDS. So in a smoking household, we would harm minimise and suggest reducing the number of cigarettes, smoking away from your baby, not wearing the same clothes that you smoke in around baby.
Providing quit resources.
Yeah, exactly, all the quit resources. But for that baby, there would be benefit in receiving breast milk versus receiving formula. And then we look at things like cannabis. So the evidence is actually not strong at all about being able to prove direct harm to the baby just through cannabis use in breastfeeding. And of course, it makes sense that data will be muddied because these women are probably not taking up cannabis smoking in breastfeeding. They're more likely to be long-term cannabis users that are probably used in pregnancy. But as we know, cannabis is stored in the body in fat for a long time and then released very slowly. But actually, when they look at the long-term or I guess up to childhood outcomes for these babies, they certainly can't say that breastfeeding is detrimental to the baby if the mother is smoking cannabis. So we would recommend to, again, harm minimise, reduce amount, but that breastfeeding is not contraindicated in mums that are using cannabis.
Nicotine replacement therapy for women who are breastfeeding. What do you... Zyban, okay.
So I'd avoid nicotine replacement therapy because of the SIDS risk. Yeah, I know. It's interesting. We think about actual smoking. Your cigarettes are bad, and that is absolutely true. Of course, it's not good for your lungs and that kind of stuff. But for our infants, it is an increase in SIDS risk because of nicotine directly affecting babies' arousal centres. Caffeine's another one that we, I think parents worry about. And of course, I would never deprive a new mum of her caffeine, and we can be very reassuring that it is safe. So it is true that caffeine readily gets into the blood and it readily passes into the breast milk. It's also true that our newborns and preemies do not metabolise caffeine very well, so they may be an at-risk group. But you're probably looking at 10 coffees a day is fine. So if you wanted to be very careful about that, we know the peak caffeine is at 1 hour post-ingestion and then it starts to fall. So probably breastfeeding with your cup of coffee, your 10-shot latte would probably be the way to go, and then having that 2-3 hour break afterwards so that your levels are coming down.
At the 6-week check, patients are already asking me about weight loss, exercise, and with the new medications like the GLP-1s as well. I think there is so much weight stigma, and we talk to women about gestational weight gain, and women are then worrying about weight loss when they're also worrying about feeding their baby. How do we approach those discussions?
I think it's a really important area and certainly something we discuss with our women very regularly, and you're exactly right. And I think the impact of exercise and caloric restriction is very individual for every breastfeeding journey. No two breastfeeding journeys are the same. And there are some women who will be able to sustain increasing safe levels of exercise to quite large amounts of exercise, and their supply will be maintained. There will be others who will absolutely note a reduction in the supply. But we also know that this is reversible. Baby will respond to a reduction in supply by wishing to feed more, making sure we're really well hydrated. And if this is identified, it can be reversed by the things that the supply and demand about feeding baby more regularly and backing off in terms of that increasing exercise. So getting to know your breastfeeding journey and having early help if there's any issues there. Caloric restriction, again, I think Mother Nature thinks she's done a wonderful job. If you are able to breastfeed a baby and maintain your weight, she thinks she's won that, whereas we definitely don't feel that is the case. But acknowledging that this has a strong biological basis, and there will certainly be people who will lose weight while breastfeeding, but there are certainly people who do not, and that is completely normal.
Yeah. I tend to find the ones that lose weight in breastfeeding are the ones that have never had a weight concern. And in fact, I've got plenty of women that really struggle to gain weight in breastfeeding and that they're very concerned about that. And then, of course, all the women that have struggled to lose weight in their lifetime tend to be the ones that also gain in breastfeeding, which when they're hoping that would be a lovely side effect for them, it's not their story. Breastfeeding is fully established by 3 months, and therefore supply is a little bit harder to knock off at that point. So I usually see if women are happy to just give themselves a well-earned break and see where their journey is at the 3-month mark before we start embarking on a more, formal weight loss journey. But of course, I'm very big on supporting whatever the woman wants to do as long as she is fully informed of all the potential outcomes.
To wrap up, would you both like to share your key recommendation you want clinicians to take away from this episode? Anything that I haven't covered, anything that you want to throw in?
For me, I think it is access to high quality care that acknowledges the mum and the baby and utilises the small amount of evidence we have in this journey rather than relying on conflicting stories from various people in their lives that is not evidence-based, because I think that is very traumatic in itself, having an enormous amount of conflicting evidence. So having resources that we can refer our women to and planning ahead for those postnatal supports and thinking ahead whilst we're pregnant for the postnatal and who are those people we're going to have in our team to help look after us when we're breastfeeding.
I did forget about another really good resource for healthcare professionals. That's the Academy of Breastfeeding Medicine Protocols, and they are fabulous. I actually give these to my patients, even though they are quite medical. They are completely referenced, and they have ones on anaesthesia and breastfeeding, supporting the breastfeeding mother undergoing surgery, supporting the breastfed infant undergoing surgery. Lactation suppression, increasing milk production, mastitis management. There's really everything around breastfeeding in there, and they are free from the Academy of Breastfeeding Medicine website. So I definitely recommend having a look at those. For me, I think the biggest take-home message is really embracing that no two breastfeeding journeys are the same. No two boobs are the same. No two babies are the same. So for a woman, even having her second or third or fourth breastfeeding journey, this will be unique. And it also means that our advice must be unique. And I think understanding the broad spectrum of normal is pretty important when we are then giving advice to help women. I also think just having a bit of humility around just really accepting that you may not know a lot about breastfeeding, and that is totally okay. We have not prioritised this as a healthcare priority. Education is appallingly low, and it's okay to say, I actually don't know. Let's either look this up together or who, let me think about who I can refer you to. I think I'd prefer that to come out of someone's mouth than a whole lot of sort of well-meaning but possibly misinformed and unhelpful information.
Probably at the heart of this issue is gender inequity, and as the Women's Health College, RANZCOG has a role and a responsibility to support and promote women, and so much part of that pregnancy and postpartum care is their breastfeeding journey, and I really appreciate the insights that you both have shared with us today. On that note, I'll say thank you. You can find resources discussed during today's episode in the show notes. If you enjoyed this episode, please rate, review and subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.